Welcome to Weekly Neurology Deep Dive. Just a quick note before we get started. This deep dive is just for educational purposes. It doesn't have any commercial intent. We're going to be diving into a recent paper today. It's all about anti-IgLON5 disease. We'll give you the highlights. But remember, this is really just a starting point. For the full picture, be sure to check out the paper itself. We'll give you that citation at the end. Now let's talk about anti-IgLON5 disease. This condition is particularly relevant to your daily clinical practice. And in the 10 years since its discovery, we've learned a lot. But there's still so much to uncover.
It really is fascinating how this disease was discovered. It was a true collaborative effort. You had sleep medicine specialists involved, neuroimmunologists, and even neuropathologists. It just goes to show how interconnected different fields of medicine can be.
It's like a medical mystery.
Yeah.
Everyone brings their expertise to the table. Now, how common is this disease?
Well, we don't have precise prevalence figures yet, but a study from a major referral center found IgLON5 antibodies to be the third most frequently detected. They were present in 8.5% of the positive samples. So this suggests that it's not as rare as we initially thought.
And who are we most likely to see with this disease?
The typical patient is older, with a median age of diagnosis around 69. But here's where it gets tricky. Anti-IgLON5 disease can mimic a whole host of other neurological conditions, which makes diagnosis a real challenge.
So it's a chameleon disease.
Exactly. Let's break down some of these clinical presentations and their common mimics. I think this will be crucial for neurologists like yourself. First, you have bulbar dysfunction, things like difficulty swallowing and slurred speech. This can easily be mistaken for motor neuron disease, or myasthenia gravis.
So even with something seemingly straightforward like bulbar symptoms, we need to keep anti-IgLON5 in mind. What else should we be looking out for?
Another common presentation is abnormal movements, gait instability, difficulty with eye movements, ataxia, even chorea, or facial dyskinesias. These symptoms could point towards conditions like progressive supranuclear palsy, multiple system atrophy, or even Huntington's disease.
Yeah, that's a wide range of movement disorders to consider. The paper also highlighted sleep alterations as a major red flag.
Yes, and these can be quite varied. Parasomnias, insomnia, excessive daytime sleepiness, even stridor during sleep, conditions like Morvan syndrome, or obstructive sleep apnea might come to mind, but anti-IgLON5 could be lurking beneath the surface.
This is starting to sound like a real diagnostic nightmare. Are there any other presentations we should be aware of?
Absolutely. Cognitive impairment is another significant feature, with patients experiencing dementia, confusion, or hallucinations. This could easily be mistaken for a neurodegenerative dementia, or even Creutzfeldt-Jakob disease.
So even when cognitive issues are present, we can't jump to conclusions. And what about neuromuscular issues?
Patients can present with fasciculations, muscle weakness, and stiffness. Mimicking conditions like amyotrophic lateral sclerosis, it really emphasizes the importance of a thorough workup.
It sounds like we need to be on high alert for this condition. What are the key red flags that should make us consider anti-IgLON5 disease in our differential diagnosis?
One of the most important takeaways from the paper is that patients with anti-IgLON5 disease almost always present with multiple, seemingly unrelated problems.
So a patient might come in complaining of sleep problems, but further questioning reveals they've also been having some difficulty swallowing. That should make us raise an eyebrow.
Exactly. Another red flag is when a patient presents with what seems like a classic case of a neurodegenerative disease like PSP or MSA, but something about their presentation just doesn't quite fit. That's when you should consider adding anti-IgLON5 to your list of possibilities.
It sounds like the key is to be suspicious and not to dismiss seemingly disparate symptoms. But how do we go from suspicion to diagnosis? What are the tests that can help us confirm or rule out anti-IgLON5 disease?
Well, routine tests like CSF examination and brain MRI can be helpful, but they often come back normal or show only nonspecific changes.
So we can't rely on those alone.
Right. For example, about 21% of patients may have mild CSF pleocytosis, and around 41% may show elevated protein levels. But in most cases, these findings won't be enough to make a definitive diagnosis.
So what are the key tests we should be ordering if we suspect anti-IgLON5 disease?
The paper emphasized the importance of video polysomnography, or VPSG. Even if a patient doesn't report any sleep issues, a VPSG is highly recommended. It's crucial for identifying the distinctive sleep disorder pattern seen in this condition.
So VPSG is a must-do in these cases.
Absolutely. Another test to consider is HLA typing. The presence of the HLA DRV110.01 DQB105.01 haplotype is a significant risk factor. It's found in about 59% of patients.
So if we see that haplotype, it increases our suspicion.
Precisely. But the most definitive test, of course, is antibody testing. We're looking for IgLON5 antibodies in both serum and CSF, although it's worth noting that about 10% of patients may only have detectable antibodies in serum.
So we need to be thorough with our antibody testing. Now let's move on to one of the more intriguing aspects of this disease, the tauopathy. The paper mentioned that many patients with anti-IgLON5 disease develop a unique 3R and 4R neuronal tauopathy. Can you explain what that means in simpler terms?
Think of tau as a scaffolding protein in neurons. Different versions of it exist, like 3R and 4R. In this disease, these specific types are clumping up, primarily in the hypothalamus and brainstem. These are key areas controlling things like sleep and movement, which might explain some of the symptoms we see.
That's a great analogy. But the paper also pointed out that this tauopathy isn't present in all patients, especially those in the early stages of the disease. What's the significance of that?
This secondary nature of the tauopathy is a key area of research. If the tauopathy is a consequence of the immune attack, could we potentially slow or prevent its development? By targeting the immune system early on, it raises a lot of important questions about the relationship between autoimmunity and neurodegeneration.
That's a fascinating question, and it brings us to the challenging topic of treatment. The paper suggests that immunotherapy isn't as effective for anti-IgLON5 disease as it is for other autoimmune encephalitides. Can you elaborate on that?
Unfortunately, that's true. A recent study found that about 70% of patients were treated with immunotherapies, like IV methylprednisolone, IVGs, plasma exchange, rituximab, or corticosteroids, but only 36% showed a positive response, and many of those experienced relapses.
So we're still searching for the most effective treatment approach.
We are, and that's why it's crucial to understand the nuances of this disease and to individualize treatment decisions.
Speaking of nuances, the paper delved into the different clinical profiles seen in anti-IgLON5 disease. It highlighted 5 major ones, each with its unique set of challenges. Should we unpack those now, or would you like to take a break and come back to that?
Let's keep going. I think understanding the intricacies of these profiles will be particularly valuable for neurologists in their daily practice. Let's start with bulbar dysfunction. This is actually the most common reason that patients end up seeking medical attention. It affected about 23% of those in the study, with difficulty swallowing being the most frequent symptom, affecting 58% of those with bulbar dysfunction.
That's concerning. What kind of impact can this have on patients?
Well, the impact on quality of life can be significant. Some patients require dietary modifications, feeding tubes, or even percutaneous endoscopic gastrostomy. And we can't overlook the respiratory risks either. About 26% of the patients in the study experienced episodes of acute respiratory failure, often due to vocal cord paresis or central hypoventilation.
So early intervention is key. Things like CPAP therapy or even tracheostomy.
Absolutely. Now, shifting gears to abnormal movements, gait impairment really takes center stage here. It was observed in 73% of the patients, often characterized by postural instability and impaired reflexes, leading to frequent falls.
This is where it gets tricky, right? These symptoms can easily be mistaken for conditions like PSP or MSA.
Exactly, but there's a key distinction. While gait impairment is common in anti-IgLON5 disease, that prominent downgaze involvement that's typically seen in PSP is actually quite rare. It's a subtle but important clue that might help you differentiate the two.
So if we see a patient with gait issues, but without that classic downgaze, that should raise a red flag for anti-IgLON5.
Precisely. Now let's move on to sleep alterations. This is where VPSG plays a starring role. The sleep disorder pattern seen in anti-IgLON5 disease is really distinctive. It's marked by abnormal sleep initiation with poorly defined and REM sleep stages. But interestingly, the sleep architecture actually tends to normalize as the night progresses.
What other sleep-related findings should we be looking for?
REM sleep behavior disorder is a common feature, and you'll often see episodes of stridor and obstructive sleep apnea. In fact, the paper reported sleep breathing problems, things like apnea, snoring, and stridor, in 63% of patients, and sleep-related vocalizations and abnormal behaviors in 50%.
Those are significant numbers. It really underscores the importance of a thorough sleep evaluation.
Absolutely. Now let's delve into cognitive impairment, which affected about half of the patients in the study. 18% even met the criteria for dementia.
So a substantial portion of these patients will experience cognitive decline.
Yes, and while the exact nature of these deficits is still being investigated, Preliminary findings suggest that. The pattern of CSF biomarkers doesn't really align with Alzheimer's disease.
That's an important point. It helps us differentiate anti-IgLON5 disease for
Right.
other dementias. Lastly, we have the neuromuscular profile, which is present in about 22% of the patients.
Right. This profile presents with fasciculations, muscle weakness,
Uh-huh.
and stiffness, which can mimic conditions like ALS.
So we have a wide range of symptoms and mimics to consider. But I'm curious about the tauopathy. It's not present in all patients. Does that affect our approach to diagnosis or prognosis?
See, that's a great question. The presence or absence of the tauopathy does seem to correlate with disease duration. Patients with the tauopathy tend to have a longer disease course, with a median of 9 years, compared to just over a year for those without it.
So the tauopathy might be a marker of disease progression.
That's the current thinking. But more research is needed to understand the role of the tauopathy fully and how it relates to symptom severity and long-term outcomes.
This is all incredibly complex. It sounds like we've only just scratched the surface of this disease.
We have. But even with what we know now, we can make a significant difference in the lives of our patients.
So we've talked about the clinical presentations and diagnostic challenges. But what about the underlying mechanisms? What's happening at the cellular level in anti-IgLON5 disease?
Well, the paper goes into some detail about the immunopathogenesis of the disease, which is where those IgLON5 antibodies come into play.
Let's break that down. Can you remind us what IgLON5 is exactly?
IgLON5 is a protein. It's a cell adhesion molecule found on the surface of neurons. It's part of a family of proteins that are involved in various neuronal functions, including synapse formation and neurite outgrowth. But the specific role of IgLON5 itself is still not fully understood.
And these antibodies are targeting this protein, disrupting its function.
That's the prevailing theory. Researchers exposed cultured neurons to these antibodies, and they observed a reduction in IgLON5 clustering on the cell surface.
So the antibodies are preventing IgLON5 from forming those crucial clusters.
Precisely. And this reduction in clustering persisted, even after the antibodies were removed, suggesting a lasting impact on IgLON5 expression.
This all sounds pretty detrimental to neuronal function.
It is. Studies have shown that prolonged exposure to these antibodies leads to disorganization of the neuronal cytoskeleton. Think dystrophic neurites, axonal swelling, and problems with dendritic growth. These structural changes can significantly impair neuronal function.
And this might be the link between the autoimmune attack and the neurodegeneration we see in these patients.
That's a strong possibility. And there's growing interest in the role of the innate immune system as well, the interaction between the antibodies and components of the innate immune system, specifically FLC receptors, might also be contributing to neuronal damage. This is another area where further research is needed.
It's a complex interplay of factors, and we're just beginning to unravel it. But this brings us back to the treatment challenges. If immunotherapy isn't always effective, what are the options for managing these patients?
The paper stresses the importance of individualized treatment. We need to consider symptom severity, the patient's overall health, and their response to previous therapies. For patients with mild symptoms, a watch-and-wait approach might be appropriate. But for those with severe life-threatening symptoms, immediate intervention is critical.
And that often involves addressing the specific symptoms rather than just focusing on immunotherapy.
Exactly. For example, managing breathing difficulties with CPAP or tracheostomy, or addressing dysphagia with dietary modifications or feeding tubes.
So it's about taking a holistic approach. But what about the search for more effective immunotherapy options?
Researchers are working on identifying patient subgroups who might respond better to certain treatments. For example, early initiation of immunotherapy within the first year of symptoms has been linked to better outcomes. Additionally, patients with lower levels of a biomarker called neurofilament light chain in their CSF before treatment tend to respond better to immunotherapy.
So we're moving towards more personalized treatment approaches.
We are, and that's a significant step forward. Another promising avenue is investigating different combinations of immunotherapy drugs and optimizing treatment protocols. There's still a lot to learn, but with continued research, we're hopeful that we can find more effective ways to manage this complex disease.
It sounds like there's a lot of exciting research happening in the field of anti-IgLON5 disease. But for neurologists on the front lines, what are the key takeaways? What should we be doing differently in our practice based on this new knowledge?
I think the most important message is awareness. Anti-IgLON5 disease is a relatively new condition, and it's often misdiagnosed. It can mimic a wide range of other neurological disorders, so it's a true diagnostic puzzle. Neurologists really need to have this disease on their radar, especially when they're evaluating patients with atypical presentations or those who don't quite fit the classic picture of other conditions.
So we need to broaden our differential diagnosis
Yeah,
and consider anti-IgLON5 disease more often.
exactly. A thorough history is crucial, and careful attention to those red flags we talked about, the multiple, seemingly unrelated symptoms. And if suspicion is high, even if those routine tests, like CSF examination and brain MRI, are inconclusive, don't hesitate to order more specific tests like VPSG and IgLON5 antibody testing.
So we shouldn't rule out anti-IgLON5 just because initial tests come back normal.
Precisely. Sometimes you have to trust your gut instinct. If something feels off about a patient's presentation, it's worth pursuing further.
That's great advice. Any final thoughts for our listeners?
Anti-IgLON5 disease is a complex condition, and it can be challenging. But with the knowledge we've gone over today, neurologists can be better equipped to diagnose and manage these patients. And with continued research and collaboration, hopefully we'll unlock even more effective treatment options in the future.
We've covered a lot of ground today. To recap, anti-IgLON5 disease is a rare but increasingly recognized autoimmune neurological disorder that can mimic a wide range of other conditions. It's crucial for neurologists to be aware of this disease and its varied presentations to ensure timely diagnosis and appropriate management. For a deeper dive into this condition, be sure to check out the full paper, Anti-IgLON5 Disease 10 Years Later, What We Know and What We Do Not Know, by Grouse et al., published in Neuroinflam 2025, 12.E2000-353. That's it for this week's Weekly Neurology Deep Dive. Thanks for joining us. And until next time, keep those brains engaged.